Can you guys see, Ebony, can you tell me if it's seen well?
If you can make it in presentation mode, I think.
It is in presentation mode.
Okay, thank you.
Can you see it?
I can see
We're
it.
all good?
Okay, thank you, Ebony. So as Dr. Kane said, I have a passion for anesthesiology, but I met a lot of people say that I should have been an oncologist because I love oncology, and particularly in the context of perioperative medicine. So around 15 years ago or so, we started looking at whether anesthetics and what factors related to the perioperative period would influence tumor progression. So as a conflict of interest, nothing will that I'm presenting is related to either my federal funders or my private funders. So no, I will not disclose anything related in this talk related to this. So the objectives are to summarize the current evidence. Some of the evidence come from my group, some from other groups, as you can imagine, on the impact of propofol-based TIVA. TIVA stands for total intravenous anesthesia. It's a way that is very common to give anesthesia. For instance, in Europe, everything goes through the vein, or volatile anesthetics. But those who have had surgery are more familiar perhaps with volatile anesthetic. It's basically gas anesthesia, and whether this would influence oncological outcomes. And then also whether regional anesthesia, or what we call a block, for instance, an epidural or a spinal, would influence oncological outcomes. And last, whether intravenous lidocaine. Intravenous lidocaine is a local anesthetic that sometimes we give intravenously to relieve pain or to enhance the recovery of our patients. And this has been something that I've been studying in my lab for a few years, and whether this would influence oncological outcomes all after surgery. So then, and I'll start with a case, because I always like to have a case so everybody has in mind of what we are facing, so to speak. And let's say 48-year-old women with a stage 1A triple negative breast cancer, hypertension, taking amlodipine, recently placed on Ozempic, and I have a call from the pre-op clinic, and this was a real case a few years ago. The patient is requesting regional anesthesia and total intravenous anesthesia to decrease cancer recurrence, because this patient has seen it on the internet, and she is requesting this. So where is this idea coming from? The idea is coming from, especially from more than, or 20 years ago, I should say, or a little bit more 20 years ago, when Shamban Ben Eliyahu and some other scientists in Israel, and some of them here in MD Anderson, proposed that at the time of surgery, there is an increased risk of cancer progression. And this would be related mostly to surgical stress. So now we know that anesthetics, either regional anesthesia, IV anesthetics, gas anesthetic, may have, at least in vitro and in animal models, cause some changes related to tumor growth or metastatic, or influencing the metastatic process. But I have to be very open and very clear here. Our anesthetics typically are given for a few hours, typically 6 to 8 hours or less is a surgery. There are cases that are much longer. And it's very rare, although here in MD Anderson, we do some cases that we have a repeated anesthetic after the main surgery. For instance, when we stage a sacrectomy or a big spine case with a stage 1 and then a stage 2. But in general, most of the folks around the globe get an anesthetic that lasts few hours. And if they get an epidural, they may be for a couple of days, but no more than that. So here we are asking a very specific intervention that is short-term lasting, whether it would influence progression, and progression by a seeding of CTCs, influencing a positive margin or lymph node, metastatic lymph nodes, or influencing what we call the undetectable metastatic disease. So a lot of people have asked the question, do any of these things influence survival? And here I'm going to start only talking about propofol, because propofol has been shown in vitro in some animal models that has a positive influence on the immune system, protect natural killer cells. Also, we will avoid the use of volatile anesthetic that, in contrast to propofol, will cause a suppression of, for instance, natural killer cells or T cells. Propofol itself has anti-inflammatory effect, while volatile anesthetics may promote inflammation depending on the context that they are given and the model that we are using. And propofol also have anti-angiogenesis effect, while volatile anesthetics would have the opposite. But all these findings were typically shown at in vitro level and in animal models. Around 2016, a paper from Tim Wigmore out of Marsden in England came out showing that patients that had TIVA, total intravenous anesthesia with propofol, has a remarkable improvement in survival after surgery for primary disease or metastatic disease. This was sort of a landmark study and an eye-opening study for at least anesthesiologists that we were interested in the impact of anesthetics in cancer progression. After Wigmore, a lot of papers came out in the literature investigating this. However, most of these papers had a particular problem. They were all retrospective. So, and as you know, retrospective studies are flawed and flooded with a lot of confounding that are very difficult to account. But most of these studies were showing that propofol perhaps could be beneficial for patients undergoing surgical oncological surgeries over volatile anesthetics. 4 years later, Makito published a paper in anesthesiology as well, looking at a very large registry in Japan, and he compared patients having TIVA and volatile anesthetic. He included almost 200,000 patients with digestive surgeries. Now, these type of studies using registries are also have their own problems. However, here showed basically no differences in recurrence-free survival and a very small, but perhaps not clinically relevant difference in overall survival. And in this particular paper, they look at the data in many ways with many statistics, matching during IPW statistics. So they tortured the data pretty good to see if they had a signal. More recently this year, there is a paper published a few weeks ago, where also using a registry out of Sweden, they look at whether volatile anesthetic or TIVA would influence cancer in recurrence after bladder cancer surgery. This particular paper shows that there is no association with the use of propofol TIVA versus a volatile anesthetic for overall survival. The number of patients is around 6,000 or 6,500. It's a good sample size. Of course, it's not the 200,000 that Makito have, but also showing at least 2 registry studies opposite effect of what Tim Wigmore, and after Tim Wigmore, a lot of people published. Now, we need to focus on much better quality studies. This is a sub-analysis of biochemical recurrence-free survival in patients who had robotic laparoscopic surgery for prostate cancer. And they compare, again, total intravenous anesthesia versus volatile anesthetics very small sample size of patients, 60 patients in each group. Oops, I'm sorry. I should say that in this sub-analysis of two retrospective studies, so the combined data, so there are some issues with this manuscript as well, but they show essentially no differences in biochemical free survival in this cohort of patients that were treated with TIVA or volatile anesthetics. Then in last year, there was Dan Sessler group shows the result of another important randomized controlled trial. This is a follow-up study of a randomized controlled trial in which propofol again is compared to sevoflurane. Here, the previous manuscript were comparing most or put all volatile anesthetic in the same bag. Here is sevoflurane against propofol. Sevoflurane is being shown to be perhaps of all volatile anesthetics, the ones that would have the worst oncological outcomes. They included almost 700 patients, over 350 in each cohort of patients, and they show no difference. So in this particular randomized controlled study, there are no difference in overall survival in patients that have received sevoflurane or propofol. Then the CAN study came up. The CAN study came up was done also comparing propofol and sevoflurane, but in this particular case, they look at patients with breast cancer. These women had a general anesthetic with propofol and sevoflurane. Around 1,500 patients women were randomized, 800 or so in each group. And again, this manuscript shows that, or this randomized control trial shows that propofol does not improve or sevoflurane does not worsen the survival of women who had breast cancer surgery. Switching gears now, one of the areas of interest is, okay, volatile versus TIVA could influence cancer recurrence or not. I show you data for that already. Now, does regional anesthesia may influence recurrence or cancer progression after surgery? And this is a graphic from a recent paper that I published with Dan Sessler. And the theory is if you have a block, in this case, we represent an epidural block, you would have a decrease in the stress response. You could decrease volatile anesthetics and opioids as well. And by doing that, at least in most animal models, you would have a better immunity, sort of speaking. So you would protect the immune system. And by doing that, you could perhaps influence cancer progression. So this is the first randomized controlled trial that Dan Sessler group did. I was part of the design of the study when I was at the Cleveland Clinic, when I was a resident, and it took nearly 10 years to Dan to finish this randomized controlled trial. A couple of things: the randomized controlled trial opened in the United States, moved to some centers in Europe, and it was finished primarily with the population of women from China. They enrolled almost 2,000 patients in the study, 1,000 in each group, and the women were allocated to have a paravertebral block or an epidural. Most of the women had a paravertebral block, or just to have a general anesthesia with opioids during their case and afterwards. In the study, Dan shows no impact of regional anesthesia on this cancer recurrence in this cohort of women. So years ago, when this hot topic of regional anesthesia was coming on, I look at our own data in MD Anderson. At that time, MD Anderson was a place that we did a lot of paravertebral blocks. And when Dan asked us to join as a center, I look at the data in our center, and we show exactly what he has found in the randomized controlled trial. Fortunately, we show that women who had a paravertebral block or no did not have differences in their overall survival, and we account doing a propensity score matching for to try to account for some confounding. Then a much smaller trial came looking at colorectal cancer patients that again were randomized to have an epidural versus a general, an epidural, combined epidural general anesthesia versus an only general anesthesia with IV opioid. Very small sample size in this study compared to the ones in breast cancer. But again, there were no differences in their overall survival after 5 years of follow-up in this particular group of patients. Dan Sessler again did another study a follow-up study of a randomized controlled trial looking at epidural versus general anesthesia in a particular cohort of patients that were older patients, and most of the patients had abdominal surgery, so they were abdominal cancers in the majority, and they have around 1,500 patients, and they had a good balance between the two groups of patients, even for the type of tumors that were included in their surgeries, and found pretty much no difference in the survival of women for cancer-specific, for the patients in cancer-specific survival and overall survival. Also, Dan did a randomized controlled trial in China, specifically looking at lung cancer surgery. This study also took him around 10 years to get complete. He launched it at the Cleveland Clinic and then moved it to China to finish recruitment of the patients. He enrolled a much smaller sample size of patients, 200 in each group approximately, with well distribution in covariates or variables. And he showed no difference in recurrence-free survival or overall survival. So most of the randomized controlled trials show that combined epidural general anesthesia compared to general anesthesia alone do not influence at least breast cancer, lung cancer, abdominal cancer progression. So somebody else did a different, using the same hypothesis, a different study looking at what we call a pectoral nerve block type 2. This is different to other studies because the PEC2 block, as we call them, is not a central or neuroaxial block. If you remember the figure that I showed you with the epidural technique going here, they look at a strictly peripheral block, not a neuroaxial block. And in this randomized controlled trial, they randomized or they allocated 700 women to have a PEC2 block plus general anesthesia or general anesthesia. And they have a good follow-up for at least 5 years. As you can see here, there is no difference on adding a PEC2 block for breast cancer recurrence compared to a general anesthetic. Again, this is a very different block to the other ones that are neuroaxial blocks. Now, I'm going to pause here and get into not a strictly regional anesthesia study, but a study that look at peritumoral infiltration with lidocaine. Lidocaine, and I'll go there a little later, has been shown to have some anti-tumor effect when in animals and in vitro. So here, these investigators from Tata Hospital in Mumbai, they posed the question of what about if we inject peritumorally lidocaine in women that have breast cancer surgery and they have a total mastectomy. So here is different to the other studies that I have shown you, that the local anesthetic lidocaine is given peritumorally. They enroll almost 1,500 or 1,600 women in the study. However, a particular concern of this is that they didn't use a placebo. Those women that had no local anesthetic, there was no placebo. So local anesthetic was given only to those who were randomized to have the intervention. And this is a particular concern. Ideally, I would have had a placebo added peritumorally. In this particular study, they show that peritumoral infiltration of lidocaine compared to nothing improves distant metastasis, locoregional metastasis, overall survival, and disease-free survival. This is the first randomized controlled trial demonstrating that a local anesthetic given peritumorally, not as a regional block or peripheral nerve block or neuroaxial block, influence long-term oncological outcomes. This paper was published in JCO. More recently, Dan and I published this paper, and we said, okay, we have a bunch of randomized controlled trials. We are going to do a mini meta-analysis. And specifically, we kept the paper that I just showed you from Tata Hospital out, because it was not a peripheral nerve block or a neuroaxial block. It was just lidocaine given peritumorally. And we showed that there's no effect of regional anesthesia, at least in cancer progression or overall survival in patients undergoing cancer surgery. And we have the data from most of the studies are done by Dan. As you can see, the sample size overall is not that large. More study may be needed, but in general, we found that in this mini meta-analysis, regional anesthesia does not impact cancer recurrence. Last but not least, I'm going to come back to lidocaine. Lidocaine, I have an interest in lidocaine because it's the only local anesthetic pretty much that can be given IV. And as you can remember from med school, lidocaine is an antiarrhythmic as well. So patients may get IV lidocaine, and FDA is approved only as an antiarrhythmic, other than a regional, as a local anesthetic. So I had an interest in lidocaine because lidocaine in vitro has been shown in animal model to have some anti-tumor effect, particularly influencing acting on cancer cells per se that express sodium voltage channels, and also in the immune system. And we published a series of studies demonstrating that natural killer cell activity, at least in vitro, when is higher when we treat cells with lidocaine. These are all the studies from my lab. And we did a series of studies, and then we look at patients who had surgery. We got natural killer cells from these patients. We know that the function of the natural killer cells goes down after surgery. We retreated in vitro with lidocaine, and we were able to somehow restore the function of these cells in patients women who had a mastectomy, liver resections, and orthopedic surgeries. So these are some of the in vitro preclinical studies that gave us the foundation to perhaps move into a clinical trial. And if doing a clinical trial, we knew that lidocaine is given IV in Europe for recovery after surgery, to reduce opioids, to reduce volatile anesthetics, and has an anti-inflammatory effect as well. So we were interested in lidocaine per se. So what I did is I joined forces with my colleagues in Shanghai, and we designed a randomized controlled trial, specifically asking the question, does intravenous lidocaine impact cancer survival after pancreatic surgery? We showed that lidocaine in retrospective studies that I'm not putting in the talk had improved at least in ovarian and pancreas surgery survival retrospectively. Why we picked pancreatic cancer is because the events were pretty fast, and there is a huge and unmet need to come with interventions that are simple, cheap, well tolerated. And we thought that pancreatic cancer could be the ideal patient population. So we did this, what we call a mechanistic multi-center randomized controlled trial. Mechanistic because we look at NETs, neutrophil traps, and because my colleagues in China have an interest in NETs formation. There are several papers that showing that lidocaine would reduce NETs formation. And for those who are familiar with NETs, NETs is one of the mechanisms perhaps for cancer progression after surgery. So we randomized around 560 patients with pancreatic cancer. We first of all look at whether we had an effect on what we are proposing with lidocaine. With reduced opioids, yes. So we knew that the lidocaine, sort of speaking, was doing not in the cancer paradigm per se, but in the what is people is proposing that lidocaine should do. Reduce opioid is working. We were comfortable with that. And we also look at the quality of recovery of a patient. And I am missing here the quality of recovery legend in the y-axis. And the patients who have lidocaine report less pain, and they were more comfortable, if you will, in their quality of recovery at least one day after surgery. So we were pretty sure in this randomized controlled trial that lidocaine is supposed to do what it's supposed to be doing in the short term. However, when we look at the survival of this patient, we show that lidocaine has no impact on the survival of our patients with pancreatic cancer, at least in this study done in China. The study has a lot of issues. First of all, we only give it intraoperatively and not postoperatively, and that is one of the major caveats in the study. We use a relatively safe, low dose and safe dose. We could have been going higher dose, but toxicity then becomes a little bit of a problem. Mostly when you are dealing with a patient population that it may have low albumin and or their albumin levels are low, so you have more chances of getting toxicity from a local anesthetic, and we didn't want to have those issues at all. So in conclusion and to finish, the role of TVA in reducing cancer progression is under investigation, but I would say that emerging data from randomized controlled trials are showing that probably those retrospective studies were highly confounded, and there is no impact of TVA on improving cancer recurrence after cancer surgery. Now we are pretty certain, I would say, or we are confident that to say that regional anesthesia probably does not impact cancer recurrence. However, and I need to make a comment here, probably intratumoral injection or peritumoral, I should say, not intratumoral injection of lidocaine or other local anesthetic may deserve more investigation based on the randomized controlled trial from Tata published in JCO last year. And that study, I believe, needs to be repeated with placebo, at least, or compared to other local anesthetics that are more potent and long-lasting than lidocaine. And also, I would say that at least short-term intraoperative infusion of lidocaine do not impact oncological outcomes. We have one randomized controlled trial, and I'm aware of other couple of randomized controlled trials that are going to finish soon. Apparently the results are negative of those trials. Now, whether we should expand the period of treatment with lidocaine to go 1 or 2 days after surgery, like they do in some places in Europe, is a possibility. They may have also some benefit in quality of recovery in these patients. Certainly, they may reduce opioid use and all things that we are concerned. But those studies need to be done under rigorous investigations, mostly knowing what happened with TIVA and with regional anesthesia. We need to be very careful on saying that anesthetic could influence cancer recurrence. And with that, I would finish, and I'm very happy to answer any questions. Thank you.